So our next speaker this morning is Dr. Oystein Fluge from the University of Bergen and Haukeland University Hospital in Norway. And he is a senior consultant working on ME/CFS within the Department of Oncology and Medical Physics there.
Well, it's a great pleasure to have Dr. Fluge here. I've known him for a number of years. I initially was very impressed with him because usually a clinician that deals with a specialty, like he's an oncologist, everything's a tumor, and pays no attention to anything else. And he had a patient that had lymphoma, but also had ME/CFS. And he didn't just write it off, he paid attention. And that's what got him involved in doing research in ME/CFS. And not only has he done this work, he's gotten a lot of other people in Norway to do it. And they often go to the meeting in London, and every presentation from the people from London is absolutely superb. It's a small country, but it embarrasses us because they're doing such fantastic work. So Norway is another great country. Thank you, Dr. Fluge.
Thank you. So thank you, Ron, for the nice words, and it's a pleasure to be here talking to you. We have had 3 fantastic days at Stanford. It's so I like so much to be among so many very clever people, learning a lot that we can take home and continue to work to finally solve this puzzle, we hope. So what I will do today is to discuss a little bit with you about our clinical trials and where we are now, and a little bit of how we are thinking. So in Bergen, which is in the west coast of Norway, our research group tries to combine the clinical work, clinical trials, defined clinical trials with translational laboratory work. We have a biobank that we harvest samples from patients in the clinical studies, both before they get the intervention and then throughout follow-up, with the aim to increase the understanding of disease mechanism, which is very important and which is often the foundation for being able to develop rational treatment. So it's true that I'm an oncologist. I'm working on brain tumors and lymphoma mainly. But as Ron said, in 2004 we had a patient with long-standing ME/CFS who got lymphoma and who resolved the ME/CFS symptoms after her chemotherapy for the cancer. And she never stopped telling me that you have to look into this because this was a remarkable experience for her, having been ill for many years. And then we started looking for these patients, and it's been at least 8 patients during a 10-year period with ME/CFS who have independently of each other reported benefit from cancer treatment on the ME/CFS symptoms. Most of these patients have received the cytotoxic drug cyclophosphamide, that I will tell you a little bit about, or the combination with cyclophosphamide and rituximab. So rituximab, that is a therapeutic monoclonal antibody that is engineered and specifically targets the B lymphocytes. I will tell you a little bit about those cells. With rituximab, we have performed a small case series, which was published in 2009. And then we tried to convince ourselves, doing a small randomized and placebo-controlled phase 2 trial, which was published in 2011, which suggested that there could be a subgroup of patients that could benefit from rituximab. Then we did an open-label phase 2 trial. That means that the open label means that there was no placebo group in that in a trial with rituximab maintenance treatment. That means that we gave repeated infusions of rituximab over time. And those data are very interesting, but it's a major limitation that it was no placebo group. So we cannot be sure about the mechanism for the observed effects. I'll show you one slide from that study. So we were wondering, is there a subgroup of patients that can benefit from B-cell depletion therapy? And therefore I will use a about 5 minutes, tell you about the randomized and double-blind placebo-controlled phase 3 trial that we published this year. And because patients had also reported effects after cyclophosphamide treatment, we have finished an open-label study with cyclophosphamide intravenous infusions for ME/CFS. And we have followed those patients for 4 years. That is a cytotoxic drug, and we wanted to follow the patients for a long time to see if the improvements were sustained. I cannot give you detailed data from that study, which is Ingrid Haukeland is the first author of, because it's only been submitted for publication. But our hypothesis has been, is ME/CFS a variant of an autoimmune disease? Is there a role for B cells and possibly autoantibodies? That means that the immune system is attacking the body itself through antibodies. This is a short introduction to the immune system. For those of you that don't know anything about it, it's the body's defense system. It has many subsets of white blood cells. We have the innate system, which is very unspecific and rapid as a first-line defense, attacking viruses and bacteria. These are the granulocytes and the monocytes and the macrophages. And then we have the lymphoid cells, which has the immunologic memory, which is specific and takes longer time to respond. Among the lymphoid cells, we have B cells. They mature to plasma cells. Note that. And plasma cells, they make antibodies to foreign molecules outside the cells. T cells that Maureen Hansen talked about, they attack foreign molecules and infections, for instance virus, inside the cells, and may also attack cancer cells. So in autoimmune disease, the immune response are directed against the body's own proteins. And then you can have autoantibodies against self-proteins. And the autoantibodies are then made from plasma cells, which mature from the B cells. Okay? A little bit to understand the Rituxamab trial, you need to know a little bit about Rituxamab. Rituxamab is an artificially engineered antibody directed against the molecule on the surface of B cell, which is called CD20. CD20 is expressed on B cells, but it is not expressed on the stem cells, the very immature precursor cells in the bone marrow. And it's not expressed on the mature plasma cells, which are responsible for antibody production. But as you can see from that red arrow, it is expressed on all the intermediate stages of B cells. And it's very effective treatment either alone or in combination with chemotherapy for B-cell lymphomas. It's been a very important drug for lymphoma, and it's also used in some autoimmune diseases. It's effective in some autoimmune diseases because it attacks the B cells. But and Rituximab treatment then gives a specific depletion. That means a reduction of B lymphocytes, both malignant B cells in lymphoma, but also normal B cells. And after maybe a half a year, they tend to reappear. So it's a transient and specific depletion. I want to show you one slide from the maintenance trial, the open label trial with the Rituxamab repeated infusions. That means what we call maintenance treatment. And these are schemes for the SF36 questionnaire, which gives information on health-related quality of life. And in this study, we seemingly had good responders. The red ones are patients that we thought had a major response to the drug, to Rituxamab. The green ones are moderate responders, and the blue ones are the 10 patients with no response. And you can, the time axis is on the x-axis is the time, and you can see I'm not able to point from here, but you can see that at baseline, patients have low values for physical function, vitality, bodily pain, social function, meaning they have a major symptom burden. And you can see after 3 months there is no change. Can you see that in this? It's not, so there's a lag time. After 6, 10, 15 months, you can see that the values are increasing, meaning that the patients respond that they are improving and feeling better. So it's gradually increasing values with maximum about 20 to 24 to 30 months. And it seems to affect all these symptoms, both the pain, social function, vitality, and physical function among the patients responding. The blue ones are completely alike throughout follow-up with no significant improvement. So there was no doubt that there was a subgroup of patients that really felt better and improved. But we cannot be sure about the mechanism from this study because it was open label without the placebo group. So the limitations of these previous trials is that you can have a patient selection because you have relatively small studies. You can have a heterogeneity of the patient sample. Like the previous speakers talked about, patients may have different mechanisms into the disease. So we had to verify or refute these data with rituximab in a new randomized and placebo-controlled trial. So Rituximab, I will tell you a little bit about that. That is a national study in Norway, multi-center, double-blind, placebo-controlled, phase 3 study using rituximab induction and repeated infusions in ME/CFS. We used the Canadian consensus criteria, and the patients had been ill between 2 and 15 years. And we could not include the very severe, those that are completely bedridden and need help for all daily tasks, because it's so difficult to get them to the hospital. 151 patients were randomized and started treatment, and they first received rituximab or placebo. None of us knew of the study personnel or the patients didn't know what. They had 2 infusions 2 weeks apart, and then they had repeated infusions maintenance at 3, 6, 9, and 12 months. Note that they had lower doses of rituximab in the maintenance phase as compared to what we had been used in previous studies. We used some kind of scoring systems. It's always a problem with self-reported recordings of symptoms that you can have recall bias, and it's not the perfect way to assess improvement. But we need to rely on that, at least partly, in ME/CFS for now, because we don't have specific biomarkers for the disease. So the patients reported how they felt every second week for a long range of symptoms compared to baseline. But we also tried to do objective measurement of physical activity by these armbands, SenseWear armbands that they used to measure how many steps they could walk, for instance. And in this study, 30% of the patients had moderate severity, and 30% had moderate to severe or severe disease that you can see. 80% approximately were women, and the mean age was around 36 years. Note that 60% had been ill between 5 and 10 years, and about 20% had been ill for more than 10 years, 10 to 15 years. So these were patients that had been ill for a long time. 75% approximately had infection prior to the disease, and they had quite low SF36 values at baseline, around 35 and 32 in the groups. This is a measure that's often given in different clinical studies, and you can use these to compare how patients are at baseline compared to other studies. So the disappointment was that there was no difference between the placebo group and the rituximab group for the self-reported measures of fatigue score or the overall response rate, which was about 30%. You can see that these lines are almost superposed upon each other. And there were no differences in subgroups either by gender, by disease duration, severity, with or without upfront infection. If you look at the SF36 physical function, you can see that it is rising slightly throughout the study, but to the same extent in both groups. It's rise from about 32 to 35 at baseline to 45, 46 at 18 months, which is an increase of 10 to 12 as of 36 points. The steps increase, but in both groups. And if we try to look at different levels of improvement, there is still no significant differences between the rituximab and placebo groups. If you look at those that had improvement for more than 30 weeks, moderate improvement for 14 to 28 weeks, or short improvements up to 3 months. And there was no difference either for patients that felt worse during the study. There were 15 patients that felt worse for at least 3 months, and they were 9 in the placebo group and 6 in the rituximab group. So it was no difference at any level of improvement or worsening. The adverse effects, there were hospitalizations, which was mainly due to other conditions. For instance, it could be a gallbladder infection, or patients having surgery for unrelated things. But every time a patient in a study is in hospital, it is a serious adverse event, no matter what the cause of it. So we had equally number of infections, 33 in the rituximab group and 30 in the placebo group, and they were common upper airways infections or urinary tract infections, so no serious infections. There were 3 unsuspected events that we have registered. One that had a woman with a bleeding and performed hysterectomy. She was in the rituximab group. One was admitted because of chest pain and possible heart attack. There was no heart attack, but she was also in the rituximab group. And one patient who had a transient paresis in the left side's extremities. She turned out to be in the placebo group. So the toxicity was not a big problem. But the rituximab trial then, it is clearly negative. Rituximab should not be used for ME patients according to Canadian criteria. That doesn't mean that single patients does not have effect from rituximab. That we cannot say. But in a group selected by Canadian criteria, there is no significant difference. At the individual patient level, I cannot claim that you have not had effect or you have had effect. But the true responders to the drug are too few in this study to give any significant difference. It gives information on the natural cause of symptoms. Obviously, placebo mechanisms are to some extent operative, but note that the majority of patients in this study had a stable clinical course during follow-up. There were few patients with a sustained and impressive improvement of the symptoms like we had seen before. 2 words about the cyclophosphamide study. 40 patients, because this is something also that we have done for the last 4 years. 40 patients with moderate to severe ME was included and had 6 infusions of cyclophosphamide 4 weeks apart, and followed them now up to 4 years. This is a cytotoxic drug, but it also has broad immunosuppressive effects, actions on many subsets of lymphocytes. I can tell you that we have interesting data and responses, but when we take into account the recent experience from the rituximab trial, we have to be careful. How should we interpret the data from this study that has no placebo group? So we cannot make any firm conclusions until we have done a randomized trial. That hopefully we can do. We are not very happy with the outcome measures that relies too much on self-reported questionnaires. So we have applied for possible future studies. We will have applied for the ethical committee now to do a pilot study measuring with Fitbits, armbands, activity clocks, continuous measuring of level of physical activity throughout follow-up, see if we can get better outcome measures. So in the last 3 minutes, just tell you what can have happened in this study. You have the problems of patient heterogeneity, the possible patient selection in our studies, previous studies. Could we have recruited patients that seemingly had a mechanism that was affected by rituximab? You have the natural symptom variation and placebo mechanisms. Patients' expectations are important for that. But is there also a true drug effect if you look back on these 12 years we have been working on this? Our hypothesis was that ME/CFS is a variant of an autoimmune disease with a role for B cells and autoantibodies. Is this still a possibility for a subgroup of patients? Remember that rituximab targets CD20, which is all the intermediate stages of B cells. Autoantibodies are made from plasma cells. These can be early plasma cells that have some CD20 on the surface, but it can also be the long-lived mature plasma cells that do not express CD20, and you cannot touch them with rituximab. And in several autoimmune diseases with a known role for B cells, randomized trials with rituximab has been negative. For instance, like you can see here in lupus, it looks exactly as in our trial. And in this study, autoantibody production is mainly from long-lived plasma cells. Some patients respond, but not the majority. And B-cell depletion does not target the long-lived plasma cell. So in spite of the negative rituximab trial, a main research focus in our group this year is to try to elucidate this mechanism. Are there autoantibodies in a subgroup of ME patients, mainly from the long-lived plasma cells, in some patients from the early plasma cells, and that being responsible for what we have observed of seemingly good responses previously. And does these autoantibodies, if they are present, have a pathogenic role? Somehow they must disturb the immune disturbance and IgG, which is an autoantibody. Somehow it must disturb the energy mechanisms, being responsible for the major energy deprivation and the clinical symptoms that Maureen Hansen talked about. For instance, the post-exertional malaise, the sleep dysfunctions, and so on. And then you have the secondary metabolic adaptations, how the body tries to cope with this defect, minimizing its problems for the body, trying to take advantage of the available fuels, trying to keep the energy mechanism as good as possible. So I think that this is what we will try to address during the next year, and try to get because it's important to know if it is the long-lived plasma cells in addition to B cells that are responsible. That could be in line with the cyclophosphamide experience and the previous observation on rituximab. But the main message is that in the Canadian criteria defined group of ME patients with no sub-selection based on biomarkers, it's not useful. I think I'll stop there.